All right, so let's go ahead and get started. Good morning, good afternoon, good evening to everyone joining this session. My name is Veena Shriram, and I'll be moderating and chairing today, and very delighted to welcome you to this session. The title of our panel is Addressing Corruption, Fraud, and Abuse in Human Resources for Health, a Policy Lens. And we're very happy to be one of several sessions at HSR this year focusing on this important topic of corruption, including one immediately following this panel. So our goal today is to really hone in on how corruption shapes and is shaped by human resources for health, by the health workforce, and what that means for policy. Now, prior to COVID and the move to virtual, our goal was to really have a very interactive, engaging session with you in the audience. And although we're not able to do that today, we really hope to bring in some of that energy and have a dialogue with you all, bringing in different perspectives from both research and practice, with a specific focus on policy approaches at multiple levels. And we're particularly interested in this session in exploring barriers to successful implementation of some of these approaches. So I want to give you a quick sense of how we'll be spending the time today. So I'll introduce all our amazing panelists right after this. And the first talk will be from Marta Schaaf. She'll give you a background on corruption and human resources for health. It'll be followed by case studies on different policy approaches from various contexts, from Shreya Haryani, Pallavi Roy, and Girija Vaidyanathan. And then Dina Balabanova will moderate a discussion amongst the panelists and with all of you regarding your perspectives on corruption in the health workforce and the policy approaches for that. Also talking about the research agenda that we need to move this field forward. And then we'll end with some concluding thoughts and wrap up the session. So on that note, I'm very excited to introduce our amazing set of speakers today. So starting with Pallavi Roy. Pallavi is a senior lecturer in international economics at the Center for International Studies and Diplomacy at SOAS University of London. She is currently the research director of the Foreign Commonwealth and Development Office's Anti-Corruption Evidence Research Partnership Consortium, and they work in 3 countries, Bangladesh, Nigeria, and Tanzania. And she has responsibility for the work in Nigeria. Pallavi's expertise is in working at the interface of research and policy, and especially in anti-corruption and governance. And she's had prior experience as a political consultant and a senior financial journalist covering policy. Also, as well as covering infrastructure and metallic commodities. And she's looked at landmark political movements against land acquisition, for example, in mining and industry in India. And then we're delighted to have Girija Vaidyanathan, who is the former chief secretary of the government of Tamil Nadu in India. She's had a renowned career in civil service in India for over 38 years, including as the principal secretary of health and family welfare. So considerable experience in health in the government of Tamil Nadu. She has also overseen departments in education, nutrition, environment, civil supplies, financing, and planning. And she's currently a faculty member in the Department of Humanities and Social Sciences at the Indian Institute of Technology in Chennai, India. Where she also received her PhD in health economics. So really thrilled to have her expertise and experience today. Dina Balabanova is a professor of health systems and policy in the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine. And she has over 20 years of experience in health systems and policy research in low and middle income countries. Her main expertise is in health systems governance, effective service delivery models, and system strengthening. And she's also a key member of the ACE consortium that I just mentioned alongside Pallavi, and has published widely on the topic of corruption and health systems. So really honored to have her here today as well. Marta Schaaf is an independent research consultant with expertise in promoting social accountability in health programs and in promoting sexual and reproductive health and rights. She consults with the World Health Organization and a range of other organizations. In her previous role at the Averting Maternal Death and Disability Program at Columbia University, she led key research on corruption in maternal health services. She holds a master's in international affairs, an MPH, and a doctorate in public health from Columbia University. So very happy to have Marta here. Shreya Haryani works with the Johns Hopkins Bloomberg School of Public Health, where she leads policy research on human resources for health at the state level in India. And more recently, she has been involved in research that explores the small private sector inequitable responses to COVID in India. And her broad research interests are in exploring the structural forces that influence health systems, particularly political actors, power asymmetries, and corruption. And she holds postgraduate degrees in public health and waste management and has 7 years of experience working on public health programs across state and nonprofits in urban and rural settings in India. So phenomenal experience from Shreya there as well. And as you can see, we've got such a wide range of interesting backgrounds for this panel. So let us dive right into the session for today, and I'm going to hand it over to Marta to kick us off on the background.
Thanks, Veena. Good morning, good afternoon, good evening, everyone, depending where you are. Okay, hopefully you can all see that slide. Veena, can you just confirm?
Yes, we can see it.
Perfect. Okay, so I'm just going to try to set up our panelists by providing some overall framing on the question of corruption, fraud, and abuse in human resources for health, with a particular focus on how it's been described and studied and what this means for the policy response. So here I just have a non-exhaustive list of some of the legally binding, normative, and programmatic work on corruption globally and corruption in healthcare. All this to say is just that at the global level, there is recognition that corruption is, of course, significant and that the persistence of corruption undercuts development goals, including universal health coverage, as well as human rights principles such as equality and non-discrimination. These commitments and statements are all informed by different assumptions about what corruption is and where the harm lies in corrupt behavior. At the same time, I want to note that we have somewhat limited behavior on corruption, on its prevalence, on its manifestations at the front lines of the healthcare system, as well as higher up in the health system, for very obvious reasons. Most importantly, that people are reluctant to discuss behavior that is illegal and or that is perceived as immoral. So in recent years, there have been approaches at multiple levels, from the health facility all the way up to the global level, to address corruption in human resources for health. So I want to move on by just quickly describing a few of the key theoretical approaches to corruption, hopefully without losing you or getting bogged down in minutiae of the different theories. So on the left, we have the principal agent theory, which comes from neoclassical economics and assumes that principals, in this case, community members, citizens, patients, authorize an agent, in this case, the government health system, to act on their behalf by providing health care. Problems arise in this because of asymmetric information, meaning that patients and community members don't always know what the rules are. They may not know which medical tests are required for particular symptoms. They may not know how much a particular test is supposed to cost. And as a result of this information asymmetry, the agent, in this case, the healthcare provider or facility leadership, has space to act in a corrupt manner and to maximize their own interest by, for example, asking the patient to pay a fee for medical care that's supposed to be free. This approach overall has been criticized for a lack of attention to context, for lack of attention to informal norms and social norms, and to structural drivers, such as the distribution of power among various actors in the healthcare system. But I describe it because it still informs the way many people think, especially in the policy space. So common policy responses to corruption in HRH that take this approach include things such as creating new rules, punishing rule breakers, and really focusing on the individual manifestations of corruption. Collective action theory, which you see in the middle, developed in part as a response to these weaknesses that I just described. In contrast to principal agent theory, the collective action theory starts from the assumption that all actors, including bureaucrats, healthcare providers, and patients, are trying to act in their own self-interest. So again, I think informal payments provide a good example here. Providers have an obvious interest in asking for them. Some patients want to pay them because they think they'll get better care, or because they want to distinguish themselves from the really poor people who can't pay, for example. But the problem is that these really poor people can be really hurt by a system of informal payments that costs more than they can afford or causes them to avoid seeking health care. Changing norms about asking for payments in this model is hard. It's what we call a collective action problem, because so many people benefit. So if one person, for example, tried to change the system, such as a motivated healthcare worker, he or she might be punished by others who don't want to change the system. And lastly, this third approach, which I think is the approach that our panelists are coming from, is more emic and interpretivist. This comes from anthropology and other social science disciplines, and in the way it's been applied to corruption in HRH really puts solutions front and center. So for example, this notion of palliative norms was developed by Jean-Pierre Olivier de Sardin, Aïssa Diarra, and others, and examines the way that healthcare workers themselves can try to affect change, such as by democratically agreeing on a ceiling for informal payments. Similarly, a multi-country project on corruption in healthcare led by the London School of Hygiene, Tropical Medicine, Brack School of Public Health, and others, and this is the project that Pallavi and Dina are working on, looks for approaches that healthcare workers have taken to reach widely shared goals, such as universal health coverage. So these theoretical lenses that I just summarized have been applied to describe and address a variety of manifestations in HRH, including those listed here. I think they're mostly self-explanatory. The fourth bullet point refers to dual practice, which is when a provider works in both the public and the private sector. Unnecessary procedures refers to providers forming surgical procedures, writing prescriptions for medicines that aren't required, but for which the provider is paid in some way. And the last point relates to any relationship between frontline corruption and the corruption that patients experience in their interactions with the healthcare system, and grand corruption at higher levels of the system, such as in procurement. It's important to note that we often, when we think about corruption and human resources for health, we think about the impact that this has on patients and communities from the perspective of the public. But it's important to note that corruption arises in part from the interfaces between healthcare workers and bureaucrats, between healthcare workers and politicians, who in turn have a relationship with each other. So each of our panelists is going to provide examples of what this looks like when it's operationalized. So these lenses identify and prioritize different drivers and outcomes. You can see some examples here. The principal agent approaches tend to prioritize more individual explanations, while the more interpretive approaches identify structural drivers. And again, our panelists will get into more detail about what these might look like in their case studies. So taking a more emic approach raises key questions about how to define corruption and where the harm lies. In other words, why do we care about it? One way to look at it is to care about corruption insofar as corruptions are diverted from their core aims, from doing what they're supposed to do. So one example of this is this notion of posting and transfer of healthcare workers that's mission inconsistent in a way that does not maximize health outcomes or that fails to respect the norms of healthcare worker professionalism. So another way to kind of identify the harm is to use ethics or human rights as a guide rather than the law. And this is because it's important to acknowledge that there are some behaviors that may be illegal but consistent with the human rights approach, or other behaviors that are legal but not consistent with human rights. So a lot of the corruption that happens in high-income countries, I think, falls under this rubric, that it's legal but not consistent with human rights. And here I'm thinking of a definition of corruption that relates to the abuse of public trust for private gain. And lastly, I just wanted to share this approach. This was developed by Lynn Friedman and Margaret Kruk in reference to disrespect and abuse in maternity care. But we can think of a similar approach to corruption. So it would place the greatest harm in the center of the target. This is what's identified in red. And in terms of harm, again, we can think of human rights or ethics as a guide, and factors such as morbidity, discrimination, economic losses to the poorest people, wastage of taxpayer money, inhumane treatment. Sometimes the manifestations of corruption in HRH can be experienced as coercive for the patient, and also negative impact on provider morale, as providers feel like they're part of a system that isn't what they set out to do when they decided to study medicine. And in fact, a recent paper by Eleanor Hutchinson et al. Suggests exactly this, focusing on the most harmful cases of corruption, what's there in red, and identifying healthcare workers amenable to change in order to effect initial improvements and kind of work starting from the center and moving out. So that concludes my presentation. I'm going to hand it back to Veena, who's going to now pivot us to the case studies. Thank you.
Great. Thank you so much, Marta, for that excellent overview. Before we move into the case studies, I just wanted to very quickly share some questions for reflection for the participants. So in the spirit of keeping our session interactive, we really would like to hear from you via the chat throughout the session, and certainly in the discussion portion, regarding your reflections on what the panelists are about to present and what Marta has already presented. And we have I'm sure you will have your own questions and comments. We have some questions for you that we would like you also to reflect on. And again, please share these comments in the discussion forum. And we will get to these during the portion of the talk of the session that Dina is going to moderate. But as you hear the talks, please share your comments. So the questions we have for you are, have any of the approaches that you are about to hear been implemented in your context? What has worked and what has not worked? What are other approaches to address corruption that have been implemented in your context? And again, what has worked and not worked? Separate from the earlier question in terms of what the panelists are going to speak about, what else has been tried? And other policy approaches that have not yet been explored or piloted in your context that you think would be effective. What are these, and why do you think they have not been tried yet? What are some of the reasons for that? So keep these questions in mind. I'll post them in the discussion forum. But on that note, I am going to hand it over to Shreya to start us off on our first case study.
Thanks, Veena. I'm just going to start sharing my screen. Okay, Veena, can you just confirm that my screen is visible?
Yes, we can see your slides, yes.
Okay, thank you so much. Okay, so thank you for the great introduction, Veena, and Marta has already set us up with the context. So the case study that I'm going to be talking about specifically thinks about technology-driven solutions to increase transparency in the human resource management system. And the context that I'm going to be talking about is in a low resource setting in an Indian state. So just to set up, to touch upon some of the HRH challenges in this context. So there's a severe shortage of health workers with 7.8 health workers per 10,000 as compared to all of India, where there are 29.2 and much below the WHO benchmark of 44.5 per 10,000. In addition, there is also a significant inequities in the distribution of the workforce. So you can see if you take doctors, for example, there are 42 doctors per million population in some of the more rural districts, whereas the most urban districts have over 250 doctors per million. In addition to some of these availability challenges, there are also perceptions of inconsistencies in the HR processes across the HR life cycle. So if we look at the health worker life cycle, starting from production, processes like admissions to some of these health schools, attendance, and even actually attaining the degree are subject to influence. If we come to recruitment, gaining initial postings, even another example is gaining the initial medical fitness certificate, are also some of the processes that are affected by these inconsistencies. Coming to administrative transactions, once health workers are in the system, the process of salary disbursements, even disbursements of incentives that are meant to be motivating health workers are sometimes undercut by these inconsistencies, including leave management. Coming to transfers, the Martha already touched upon that, that's one area, postings and transfers, that are subject to a lot of inconsistencies. In addition to that, an indirect influencer like living and working conditions for health workers are also to some extent impacted, which ultimately affect the performance of health workers. And even the process of the annual performance review is something that is impacted. And the impact of these inconsistencies, Martha again already touched upon some of these, leads to firstly, severe shortages of health workers in the most underserved areas, demotivation of health workers, delays in program implementation. But again, on the HR side, it also influences workforce planning and managing performance, planning for recruitment and training of these health workers, which ultimately impacts service outcomes. So in this context, the state government decided that there was a need, recognizing this need to make some of these HR processes more transparent and efficient. Decided to introduce an HR information system. So the government of India has the Manav Sampada system, which has been implemented across several different states in India, across multiple departments. So some of the key features of this system is that firstly, it sort of transitioned this very heavy paper-based system to an electronic system. And it provided for the first time a mapping of all the cadres and health workers that were actually in the system, which would allow the department to see the actual availability and distribution of the workforce. Some of the other features that it builds in is, it allows for viewing of vacancies of posting, the transfers, as well as the performance appraisal process. All of these processes have been digitalized and are posted onto the system now. There are some other features such as leave management and training management, which have currently not been implemented, but these are features that in future can be implemented into the system. So just very quickly, we've studied the impact of this in the process of developing a human resources for health strategy for the state, which involved, of course, a review of literature and the data in the system, but also a prospective stakeholder analysis. So these are some of the observations and examples that that we'd like to share from this. So if we take the performance appraisal process, for example, and the transfer application process. So I won't go into the details of this, but both of these are to demonstrate that there are several steps of approval that are required. The way the system is currently set up for an officer that works at the block level to have his performance appraised or his transfer application approved. So the main advantage that this transition to an electronic system allowed was, for the first time, employees and as well as their administrators could for the first time view the status of the application in the system on their screen. Both these figures show that there are several levels of approval that are required in all of these processes. So the system reduce the risk of delay and manipulation at each of these, at each step. There were perceptions that there were inconsistencies and informal transactions at all of these steps. So implementing a digital system has helped to reduce some of these. But here are some of the gaps and some of the other observations that we also got in looking at this. One was around the data quality of the human that is in the human resource system in itself, and the processes of how this data quality issues could be resolved were also unclear among health workers. So what this did in combination and moving beyond the system was that it it led to a perception of a lack of trust in the system, because combining data quality along with some of the policies that didn't really explain how the decisions were ultimately made. So even if somebody put in an application through the system, the ultimate decision, the outcome of that decision was not clearly communicated. So that sort of comes into the area of moving beyond the system and thinking about the policy in itself. Another aspect of this that we realized was that even when the system was built, the process was built to go with the formal policy and made this digital system available to make those applications. People in the system still felt that their application would not be successful until they added this extra weight to their application, whether it was in the form of influence or any sort of payment. So these perceptions continued to remain in the system. And then lastly, we also looked into some of the factors for some of these pressures that people were under to actually go around the system, and the main one that emerged, at least in the posting transfer system, was the ability to live with family and sort of the working and living conditions of health workers. So all of this to say that, if we consider so this is the YN framework from 2008. So if we were to consider the different drivers that lead to, some of this abuse of power for private gain, building a digital system, like Manu Sampada can allow, and access to information can help with building transparency and to some extent discretion, accountability, and citizen voice. But as we saw in some of the examples that I mentioned before, that there are other factors at play, like incentives that health workers considers, for example, living conditions, as well as this norm that nothing gets done in the system, or this perception that nothing gets done in the system without this extra weight. So all of these factors have to be taken into consideration. So all in all, to say that strengthening the data quality is the first step of strengthening the human resource system, because it is can be a very valuable tool in improving the transparency in the system. In addition to it's not necessary but sufficient. There are other policies and interventions that would be required to address some of these informal norms to increase accountability, as well as an overall, the overall context of improving some of the other challenges that health workers face in the system. So I'll stop there and hand it over to Pallavi to present us a different case study. Thank you.
Thank you so much, Shreya and Marta. Actually, it's a really good way to get into what I want to be talking about. And just a second, I'm just trying to get screen to share. These are, yeah. Can you let me know, Veena, if you can see my screen?
Yes, we can see your screen.
Okay, great. But can you see it in just PowerPoint mode or?
Yes, it's in full screen mode, yes.
All right, perfect, excellent. Thank you. Thank you very much. So what I'm going to talk about actually picks up from something very interesting that Shreya talked about, that there is something more beyond the system. Despite having the information systems in place, there were norms that were at work that actually impeded enforcement. And that's something that's very key to what I'm going to be talking about. And I'm an institutional economist, so it's an absolute privilege to be working among such specialists in the health and governance sector. And it's really good to see that we have this dialogue between two sides that normally sit on two sides of the fences, but we really need to join the dots, which is why this presentation is really titled Looking Beyond System Inefficiencies. And that has extreme policy relevance, and I'll talk to that when I move forward. But I just wanted to lay the base for the kind of work that we're doing in the Anti-Corruption Evidence Program. I know Veena referred to it, and my colleague Dina is also there. The Anti-Corruption Evidence Program is a £6 million program on generating evidence for anti-corruption policies across 3 countries, Bangladesh, Nigeria, and Tanzania. And health is a big component. We also work in other sectors like electricity and agriculture. And in health, the London School of Hygiene and Tropical Medicine is a key partner for that. And we're doing this work together, and some very interesting early results to talk about. But first, I just wanted to lay the base for why we talk about corruption and what is really the benchmark for what should be the aim for a lot of us working on anti-corruption, whatever the sector might be. And in our framework, which is the political settlements framework coming from institutional economics, what's important is that we have both effective vertical as well as horizontal enforcement. Now, vertical is something that we all understand. It's top-down, it's enforcement, it's universal accountability. It's the blunt force of the force of law, if I may put it like that. But there is another very important element to this kind of enforcement and the ability to have rule of law, which essentially means that the law is implemented universally and equally to all concerned in society or in that particular sector. And that is, to have that kind of vertical enforcement, we also need what we call horizontal enforcement. That is, everyone or nearly everyone in society who matters for that particular sector or subsector actually wants to adhere to that law, wants that law to be implemented. And most importantly, because both Marta and Shreya talked about incentives, it is in their incentive to abide by that law. If that incentive is not there, you're going to have a lot of people simply not bothering. You might have a really good formal structure of law, but people are going to end up breaking that law. So you don't have horizontal enforcement. As a result, what you therefore have is there is no rule of law. What we have is rule by law, and that's what this next slide is about, which is there is partial enforcement. Either the vertical enforcement simply does not work, or at the horizontal level, very few people really care to adhere to that particular rule of law. So you have rules, but it is just not possible to adhere to them. Sometimes you don't have the capacity to adhere to them. Sometimes powerful members of society make sure that they don't need to adhere to them. And this I will link in my next slide to why we're talking about health sector corruption. But just to say very quickly that there have been some successes, and Shreya talked about it, in terms of a sort of transparency and accountability based mechanisms for anti-corruption. For instance, you could have biometric identification. And we've seen from our work in Bangladesh that it's gone down spectacularly unpopular, because there is this whole, then doctors think there's a breakdown of trust, but equally, it is even possible to game that system, because at a primary healthcare center far away from Dhaka or from Chittagong, who's to say that somebody else is not carrying your biometric card and literally logging you in? So there are these cracks through which these kinds of formal mechanisms actually fall through. And that's because, and this is something that's common through this session, there is a high level of informality that we see at work across all our developing country contexts. Now, there is a large levels of informality even in developed country contexts, and we look at it in institutional economics as a spectrum. There is no one benchmark. Even the regular benchmark country that we like to talk about in good governance terms, even Norway will have high levels of informality, and we are talking about countries like Bangladesh, Nigeria, and Tanzania here. So it's a spectrum. But you do have very high levels of informality in the typical developing country. And that is what we need to crack. How do you get around these informal norms or informal sources of power that tend to affect governance in the health sector? And which is why I'm actually linking this in this manner to health sector and healthcare corruption in HRH, whether it's in procurement, whether it's in being present for work, absenteeism, which is what our research is on across our 3 country contexts for the anti-corruption evidence program. And essentially, we know that in healthcare systems in developing countries, the informal tends to be the norm. You can have a really good system. You can have sanctions for absenteeism. It's present across the 3 contexts that we're working in, but we do know that absenteeism is one of the biggest problems that faces the healthcare sector in developing countries. And when the agenda and the aim more and more for governments in developing countries is universal healthcare, that's a huge issue to actually sort out. As I said, this can't be about a blunt instrument, and this is where the entire issue of principal agent, modeling it in that framework starts breaking down, because just because I have more information, I know people are absent. As the officer in charge in Nigeria in a primary healthcare sector, I know this particular community health worker is absent, but I can't do anything about it. So just merely having information, which is a proxy for transparency, doesn't mean that I'm able to solve the problem. So what gives? What is it that we need to then solve in order to have that problem being policy tractable? And that's where we need to start breaking it down. It's actually quite commonsensical, but this is where we need to marry the system inefficiencies with the structural, political, macro political inefficiencies, which is people break rules for very different reasons. They can break rules because they're being absent, because you're not being paid salaries. The primary healthcare clinic is really badly maintained. There are gendered norms. Women with childcare in Nigeria, we've seen women tend to be absent during harvesting periods. They actually need to go off to their family fields and work. Insecurity is a huge problem in Nigeria that cuts across genders. And there is this huge problem of political connections, which we don't tend to talk about, but it's surprising because you've stopped to think about what health is. The political economy of health is a hugely vast subject. It's in terms of the proportion of budget, it might be small, but in terms of the absolute sums of money that people are responsible for, you're actually setting yourself up for extremely adverse political economy. And in developing countries can be a huge channel for patron-client relationships. So it's very important for us to be able to study the health sector in terms of that particular lens of political economy too. And that's what we are trying to do in the ACE program, the power structure and the systemic issues. But in a context where everybody's breaking the rules, some because they have political connections and some genuinely because of systemic inefficiencies, any top-down approach or most top-down approaches are going to end up not working. So therefore, it's important for us to address what could actually work. And I know that I'm possibly, don't have much time, but I'm going to quickly try and wrap up. I'm going to skip this and we can come to this a little later. Now, what are the drivers of absenteeism in Nigeria right now? And unlike in Bangladesh and Tanzania, what happens in Nigeria is it's an extremely fragmented society, both politically and socially. In Bangladesh, there's one political party, it's fairly dominant, it's fairly authoritarian. You'll have to have all your political connections there, so it's easier to pass through. In Nigeria, it's not just political, but there are very strong social and kinship networks. For instance, community leaders, traditional community leaders called Igwes are extremely powerful. You also have political godfathers, and godfatherism is this very potent, powerful leaders who get to choose everything from who sits in the primary healthcare center to who gets to be chosen as a candidate for election. So you have these varying kinds of political influences, and that defines how and who protects in what manner. So reasons for absenteeism are diverse. Each hierarchy has different reasons for being absent. The purely political connections tend to be for those who are more powerful or higher up in the system, like doctors. And we're picking up an interplay between the systemic and the structural. So you're going to have, and I want to pull this to a point that I made earlier, you're going to have people who will be absent even in an efficient system. You are going to have people who are going to be present even in an inefficient system. So for policy purposes, and that's where it all becomes very relevant, we need to be able to address both. We're not going to be able to address where the macro political structure is concerned, because that's an incentive structure that's genuinely beyond the kinds of policy circles that we are talking about. But in terms of the people who are, let's say, reasonably absent, or what we call the non-voluntary reasonable violators, is it possible to design policy better leave policies, let's say, better housing policies within the constraints of budget that developing economies face? And then join these up so that horizontal enforcement becomes possible. They actually don't violate the rules because it's no longer in their incentive to violate the rules. That means we might have to have an appetite for political absenteeism for a while, but as more and more horizontal enforcement starts taking place, you can actually then start putting into place the accountability and transparency mechanisms that could work across the rest of the sector. I'm going to stop now because I know Girija also has some very, very interesting issues to talk about. What I will do is I will stop the slide share. Girija, over to you. Thank you.
Thank you, Pallavi. Let me now get to sharing the screen. Veena, is that okay?
Yes, we can see that.
But I'm not on the first slide.
Yeah, you just need to go to the top of the deck. Yeah, great.
Good afternoon. As I said, I'm in the evening, so good morning, good afternoon, good evening to everybody. It is a bit of a disadvantage coming after such excellent presentations. But the advantage is that I wear a different hat. My presentation is from the policymaker's perspective. And it is really interesting to see how both of us on the two sides of the table, as Pallavi put it, are roughly saying the same thing. So I'm now a retired civil servant, so I'm free to talk about many things that I might not have been free to talk about a year and a half ago. So I hope you will all be able to see the synergy between what all of us panelists are saying. Before we go on, before I go on to discuss the subject of the day, I think I will introduce the subject of, I will try to introduce the state of Tamil Nadu in southern India, where I have been working, first as health secretary and later as chief secretary. Tamil Nadu is the 10th largest and 6th most populous state in India. It's also been recognized as one of the key performers in the health sector, not only now, but in early decades after independence. Among the key factors that identified for the success of the state has been a very robust public health delivery system, coupled with sustained political and bureaucratic commitment to human development. An important but unexplored factor in this picture is the role of governance of the health workforce and its contribution to meeting the goals of the health system. And this is why the present discussion on policy initiatives to improve the functioning of the health, human resources in health sector is very relevant. This is the outline of my presentation, but I think we will just go on. I would like to discuss two manifestations of corruption in the HRH sector, both of which are less researched and written about. Normally we talk about absenteeism and many other things, but here I feel that these two, posting and transfers and recruitment of health personnel, are very key to the issue of mission inconsistent policies, especially since they are at the root of the very problem. I propose to discuss posting and transfers first, because I feel this has much more potential for policy interventions for improvement, though I will be introducing a policy, discussing a policy intervention for improving and streamlining recruitments to the health sector, and also seeing how it worked or did not. Why are postings and transfers important? I mean, I think much of the discussion on corruption discusses why is corruption important, because there is a great feeling that we might be making too much of it. But postings and transfers are important because they are there at all parts of the health workforce. They affect everyone, and they also affect them at all points of their career. Now, when do these postings and transfers occur? I think many of you who may not have worked in the health sector would not realize how important they are. They happen all the time. There are vacancies due to retirement and promotion. There are fresh recruitments. These people have to be accommodated. Government wants to transfer people, sometimes for punitive reasons. And sometimes an employee just wants to go elsewhere. There may be many reasons. But so postings and transfers are a continuous cycle of occurrence. And why are they important? Because the right man or woman for the right job at the right place is critical to improve workforce morale as well as quality of services. I think this is, it can be repeated many, many times, because if you do not do your posting and transfer policy correctly, you will end up with a situation of informal and mission inconsistent processes where services will not be provided, the workforce morale will be very low. And so though it looks like a slightly inconsequential part of the whole mechanism, we have visually seen that the posting and transfer policy, and I think Shreya also mentioned it in her talk, and the transparency with which it can be done and the trust which is earned within the workforce is very key to improving the health services in the state. Now, the state has had, it's clearly, the state has had a very well-worn posting and transfer policy, not just now, but nearly from 20 years ago. So we are not talking about something new. What we are talking about is how this policy is working. Now, it's a very self-evident thing that most people, most health professionals want to work in urban areas. Most of them want to work in places which are near their, I think, again, it was mentioned in Shreya's presentation that people want to work near their families. They want to give their families good infrastructure while they're growing up. So what happens as a result of this? The competing drivers between personal self-interest and the system interest result in the backward districts becoming vacant, and people crowding the available health workforce, crowding into, if it is not regulated, the available health workforce crowds into places where they are not, where they are actually not that much required. And this is how, and as a result, the backward districts are left, vacant. So in order to address these issues, as I said, we came up with this transfer policy, and this is called transfer counseling. Now, people who have not heard this term would think it means something like psychological counseling, but actually transfer counseling was formally adopted in the year 2002, and it was actually borrowed from the education department, where it had been followed very successfully for teachers. The main feature of this policy is that the available vacancies are made transparently available, quote unquote, to the applicants, and they are allowed to make a choice. And then these choices are accepted based on certain established guidelines. Now, please note that the definition is complex, that the important features are making the vacancies known, allowing the applicants to know about the vacancies, but note the little point there saying that they would be accepted based on guidelines. Now, the other thing we used to do, because this was long before the era of computers, this was conducted, counseling as a process was conducted physically in the state headquarters mostly, and sometimes in the district headquarters for the eligible persons. Now, this counseling policy has been written many times, but the last good draft came out in 2007. That is, again, about more than 12 years, 15 years ago, around 15 years ago. It lays down nearly everything that is required. How often will counseling be done? Where will it be done? What vacancies will be notified? Who will be eligible to be counseled? How will priority be decided? So it is almost a very elaborate and thorough document on how it would be done. The same policy, the transfer policy, does not just stop with this making vacancies available. It also has put in place certain non-monetary incentives for filling up postings in remote areas, which I will be discussing as a case study. Now, how well has this policy succeeded? I think that is a question we'd all like to ask. It's been in operation for 15 years. Of course, we had an exploratory study in 2014 which showed that by and large personnel are aware of counseling norms. As a matter of fact, they are by and large satisfied. The policy, though it is not completely known to everybody, it had actually, the health system actors broadly accepted that this reform is a positive development, highlighting the benefits by way of ensuring convergence between the expectations of the individuals and the goals of the health system. So this is what we found in a small study, and this is what is the perception locally, that the position prior to counseling and the position after counseling, definitely for the worker, it was a win situation. Now, what happened? Is it really a perfect system? No. The counseling process is often vitiated because many things happen as was said, many informal developments are happening. Many of the valuable postings, many of the valuable vacancies, especially in urban areas, are not shown during counseling. Interestingly, the higher level administrative posts, like that of the joint directors and deputy directors, who decide various other things about the postings and transfers, they are not filled up through counseling. They are filled up directly through other processes. And even though the detailed guidelines for counseling have been given, nobody is doing it exactly as per the guidelines. And this is exactly what Pallavi said, that there are many guidelines, many laws, but people are not following them. Even among the staff themselves, they did not want third-party supervision. As a matter of fact, there was a suggestion that there would be third-party supervision of all counseling processes, but this was most opposed by the staff themselves. So this is the reality over these last 15 years. Of course, it's variable depending on who is in charge at various points in time, but this is a reasonable picture of how it is seen. I'm just presenting 3 case studies because one would know that the transfer and posting policy is much more complex than the 3-word definition that we are giving it. The first case study I'm talking about is a slightly positive one, and actually Tamil Nadu's experience here has now been spread to the whole country. Since the 70s, the state came up with the policy that 50% of the seats for postgraduate admission. Now, those who know India know that getting postgraduate medical admission is a very, very difficult process. So one of the ways in which doctors were incentivized to do rural service was to say that doctors who completed 3 years of rural service would get a reservation for postgraduate admission. Now, this worked excellently well, and we never had a problem to fill up our rural postings. I'll come up with what really happened, but at least during the counseling, doctors opted to go to the rural PHCs. We further improved this policy by making an internal reservation for doctors and extra marks for doctors who went to hilly areas, because that was one of the areas which we could not fill up posts. The doctors willingly came forward to work in both these areas. And again, completely win-win situation, a kind of intervention that worked for everyone. Now, the second story is not that positive, because this is what really happens in the field. The doctors and nurses who are formally posted to remote and backward areas during the counseling process are then informally diverted or deputed. Now, these are words which nobody really understands the meaning of, but they have become used in common parlance. They are sent away to convenient locations, that is meaning roadside postings where there is less work and they can do dual practice, keeping the remote posting vacant. Now, unfortunately, the power for this deputation and diversion has been given at the field level, because this is actually justified as to keep the PHCs running. Now, suppose there is an emergency, suppose there's an epidemic in a PHC, you have to divert doctors. So the local field official needs the power to send doctors or nurses or other personnel from one PHC to the other. And using this power to keep the system running, doctors are effectively sent from one place to the other. And the unfortunate part is that this is an informal process, so nobody knows what is happening. Nobody knows how long the deputation or diversion lasts. So the entire process, formal process of counseling done to fill up the remote PHCs is effectively hijacked, and there is a whole sense of temporariness of flux, because the unlikely doctor, the one who has, there are two types of doctors who are diverted: the one who is powerful and has some other way in which he lands up in a posting of his choice, and the other doctor or the other nurse who has no voice and who is sent to a place where she has a very heavy workload. So this is one of the practices which is a clear example of how informal practices can take away from formal guidelines. And of course, the only way to get over this is clear guidelines. But again, as was mentioned in the presentations that follows, there's no easy answer. Even strict, everyone knows this exists. Most people accept it as a way of life. So in order to get rid of this, we have to do a much more effective way of getting the system to understand the damage that the deputation and diversions are causing. Now, this is the last one, last thing. This was again interesting, because when new nurses were posted to rural PHCs, they were trained to handle the system or maternity at the PHC level. Unfortunately, they were told that they had to work there even after they finished their training period. One set of nurses found a political patron to move themselves into an urban hospital. Now, how they bent the guidelines, no one knows, but they moved themselves, and as soon all the other nurses who were quietly working in the rural areas, once they had a look at what they saw was unfairness, they raised their voice, and all of them left the rural PHCs. Now, this was one of the cases where the transfer guideline was completely given the go-by. Closing the Pandora's box was really, really difficult, and we had to work extremely hard as policy advocacy to the persons who caused the damage in the first place, convincing them in various ways, including we had to scare them with audit objections, saying that the doctors and the nurses had to be retained there. But the good news is we did manage to close the box. And the even better news is the boxes remain closed. I think people have seen that the disadvantage of letting all the rurally trained nurses move en bloc to urban areas. So in view of the time shortage, I'm rushing through this part of the presentation. The recruitment of health personnel when I joined as health secretary for the second time was extremely ad hoc. Vacancies were not at all declared properly. Different agencies, now this is again unique to India, different agencies were recruiting the same staff for their purposes, each one in a different manner. So doctors were recruited on contract basis, some doctors were recruited on regular posts. Even though we had more doctors and more nurses and more lab technicians than we needed, we could do nothing to do a merit-based exam. So in 2012, we set up what was called a Medical Services Recruitment Board. Now, again, this recruitment board has been in vogue for nearly 7 or 8 years. And what I can say is there have been some plus points. Entrance exams are now being conducted. There is a recruitment calendar. The list of qualified candidates is now being done with much less ad hocism than it used to. But even in spite of this, some of the lists go to certain directorates who are not issuing them posting orders. The court process in India is again another interesting thing. Though it is normally meant to safeguard rights, it is sometimes used to hijack the recruitment process. And once this pandemic, again discussing the impact of the pandemic on these informal practices will be a separate lecture altogether. But as a result of the pandemic, parallel recruitment and outsourcing once again started, which meant that all the good work that the board was doing has been devalued to a large extent. So I hope these two examples have given you some idea of how complex the whole system is in practice, and how policymakers also struggle with how to carry out policy changes to reduce the overall levels of these informal practices. Now, why do these happen? I think once again, all my previous speakers have said quite a bit on this. The complex systems of patronage, the monetized value of postings, the overarching societal forces that drive this corruption. Now, different stakeholders here, especially the personal interest is very high. So different stakeholders have different interests, and all of them are not in sync with the mission objective of giving good health services at the remote location. Now, very often the individual voice is not heard against the voice of the group. Information asymmetry is very vast, and this is what Shreya addressed when they tried to computerize. And what is the mission objective even known to the whole group is something we wonder, because I don't think we spend enough time trying to tell health workers what they're really working for. Now, this last slide or slide before the last one is more from my personal experience. How do we make this work more rather than less? Make the policy as simple as possible. The political executive is not our enemy. As Marta had said, it is not just the interaction. It's a very complex interaction between all the forces. So to get the buy-in from the political executive for the reforms we're carrying out, show them the link between the implementation of a transparent policy and better outcomes. Work with staff associations, listen to legitimate requests. This is very important. The employees should perceive that the dissatisfaction and discomfort are fair. This is from your nurse example. Once one person gets something, everyone wants the same thing. The second one is, fourth one is echoing what Pallavi said, consistent discipline against the non-compliant. Now, don't target the ones who are doing something which is, as she rightly put it, very trivial forms of informal practices. Target the ones who are actually devaluing the way the system works. The next one is complete information required if you want to do a better job of monitoring what you're doing. Define the mission clearly, as I said earlier. Do not think that people know what the mission is all about. It's the policymaker's job to make people understand that everything they do has an impact on how the system works. The last slide, which is was on the ideas for research, but since we will be discussing it in a later with Dina, I will stop here and hand over to Dina. Thank you.
Great. Thank you so much, Girija, and thank you, Pallavi. Thank you, Shreya. Fascinating case studies from the three of you. And without further ado, I think let's hand it over to Dina to carry us forward with the discussion portion of today's session. Over to you, Dina.
Thank you very much, Veena. It was fascinating to listen to all these case studies and examples. We very often don't talk enough about corruption in the area of HR, a lot of the published literature is around informal payments. We are now learning about absenteeism, but these are areas that are particularly problematic. I would like to kick off by asking you and a few questions. We also have questions by the audience, and we'll try to cover some of those. So first of all, you mentioned something, and I think you talked about this, how there are these legal frameworks, so there are these attempts to neutralize these practices, but people don't follow the rules. So these practices end up being bypassed and not working. And we often talk about corruption as a problem-solving exercise. The fact that the system is not fit for purpose, or there is another problem, or there is, as you said, I think when Marta was talking about how people can't break the rules because there will be another group of professionals who will object to that. So basically, how can we make why is not working? You're doing these great initiatives and they don't seem to be working. Can you maybe make a few comments of what is the problem? We'll start with Girija.
As you said, why don't they work? The forces, as you rightly said, seem to be working against each other. And it's almost counterintuitive. For instance, to say that when we tried the transfer policy, we said that doctors who are in districts with high level of vacancy cannot appear for counseling. Now, this was very fair from our point of view because we did not want those doctors rushing to districts which already had enough doctors. But from the doctor's side, it was very unfair. They said, look, we've been suffering here already. Why don't you let us go? So the real problem is, as was pointed out in all the presentations, between legal and ethical, between legal and fair, and between the mission objective and the personal interest, there seem to be, it is clearly not incongruence. So how do we work a policy? Like when we worked with the getting doctors into rural areas so that they can get postgraduate seats, everything was working in the same direction. The doctors knew very well that if they worked in the rural areas for 3 years, which was everyone had the same rule, they had an advantage in getting a postgraduate posting. So there was nothing incongruent. So I think I think that's what Pallavi also mentioned and Marta also mentioned, that when we can get them in line, when we can get in simple incentives in line, then policies work. But when we try to do things, even in this doctor's case, we had to do a lot of advocacy with them. And then we had to work out simple measures by which the doctor, if they worked for 1 year, would be replaced by a newly recruited doctor. So we had to tweak the policy to make them understand that it was fair. So I think all these ideas are coming in together.
That's great. And what you just mentioned was really important. I want to call Pallavi and Marta to comment on this, whether the incentives, understanding you work with these people to understand why would they do why would they follow the policy? Because individuals are not the organization. The individuals have different perspectives, different interests. We should not believe health workers are there to do a wonderful job and that's it. They have their own very often social role. So Marta, would you like to comment on this aspect of why the rules are not following, how we take into account the incentives?
I think to get back to your framing of fit for purpose, I think it's really important to try to figure out, and this gets back to the utility of this EMIC approach, and I think reflects a lot of the things that people have been sharing in the chat about all the challenges they've encountered, and that is understanding why, just starting with understanding why people do what they do, rather than saying, you're supposed to not do X, and we see that you're doing it, so we're going to fix the rules, but instead to say, what's happening? Why are everybody in this sort of health system ecology from top to bottom acting the way that they are? And then how do we, if we identify that a harm comes from that, how do we shift the system so that those harms no longer occur? And I think for some people, there was just an experience shared with informal payments in Senegal, having some empathy for where people are. And I think going from Girija's points about people who they want their kids to go to a good school. That's completely understandable. So starting from this point of empathy and working with understanding why people do what they do, and then working with them to change that, I think is a great starting point.
This is what we call people-centered systems, trying to see them not as a provider, not as somebody to be deployed. I don't like the word deploy, because they are not human. They are human, and we need to think about their role. So, Pallavi, you talked a lot about, in your discipline, you talk about collective action, the roles of, say, professional associations, and in high-income countries, we talk about self-regulation. What can you tell us? Is there something interesting that could help us solve these problems there?
So, yeah, thank you. And I completely agree. Girija, fascinating presentation. Tamil Nadu has always been sort of one of the more fascinating states where, politics works actually sometimes in very, positive ways to deliver outcomes. It's not always an adverse political economy, despite the fragmentation and the factionalization. Coming to your point, Dina, yes, collective action often fails, as we all know, largely because of the free rider problem. And that becomes a big issue when we are talking, especially in the healthcare system. And we're learning as we go along as institutional economists who tend to normally look at, say, other sectors and tend to leave health to health specialists. It's a very different ballgame. What works, for instance, in the electricity sector in Nigeria, and I'll speak with my Nigeria hat on right now, will not work in the Nigerian health sector because the health sector itself is a kind of, I'd say, a complex where you don't have just the political, you have the social, you have the familial, you have the individual. It breaks down at very, very different levels. And understanding the incentive structure of all those is extremely important. We need to understand the hierarchies that are concerned, the incentive structure of every hierarchy. Midwife is as important in a country like Nigeria and in a primary healthcare center as the doctor is. But a midwife will have a very different set of incentives from the doctor. We need to bring in gender, therefore. And while you're parsing through all of this, you also need to then talk about the political connection. Chances are the midwife's political connection is the community leader. Highly unlikely that the midwife's political connection is going to be a very highly elected representative at the local government level. But we therefore can't have the same kind of accountability norm for the midwife as we have for the doctor. And that's not something that I think healthcare practitioners have understood so far, because we're looking at a systemic inefficiency from a sort of more helicopter point of view. And I think the more we parse through, the better we will be able to understand. Normally, if I were wearing my institutional economist hat, I would say, just understanding corruption doesn't give us the answers. There has to be a lot more. But I think in the health sector case, we really need to understand where the inefficiencies are, because systemic inefficiencies are more deeply rooted in the health sector than in other sectors, whether it's in agriculture or it's in electricity. I'll stop here because I know, Shreya, Veena would have other very...
Thank you very much. I would like to now turn to the other panelists, but we have some amazing questions from the audience. Thank you very much. So at the first one, if I can summarize, we cannot cover everything, but really interesting question about, we have a lot of this performance-based financing, and the idea is that you assess individual performance. That's a slightly Western thinking, and we see this in many countries. And here Mary Hadley is giving an example from Bangladesh, which is saying that actually that's not really working because it's not culturally acceptable to grade health worker negatively. They all receive 10 out of 10. Which is clearly not their differences. Are there any good example of systems where this works? And again, the other slightly related question is, do we know at what level a salary needs to be to prevent health workers from wanting to moonlight? Are there any, and working dual practice, so are there any other methods of reducing this practice? Also, this happens in the UK. I just wanted to say, I read a study, not in health, in civil servants, where I can't remember what country, they increased, it was Western country, they increased the salaries, they gave them bonuses, and the performance and the good practice they wanted to encourage only was for very short time. So I'm not sure. So I would like to hand over to Veena. So the question is about PVF, how do we assess individual performance? Clearly, it's not something that we can do in many settings. Or you could answer the question about how much is enough. Can we just give them more money and that's it? They'll stop going in the private sector.
Yeah, so I actually think I want to hand this question over to Shreya, because I think Shreya's got some really interesting perspectives on this from her field work on this very topic about
Fantastic.
how do you assess and measure performance, and how effective is it, and what are some of the ways we can improve the system. So over to you, Shreya.
Hey, so I'm going to take a crack at trying and answering this, and then maybe others can add if I miss on anything. So just thinking about performance, I think, this question around what is this salary, or what is this amount that we can pay them in order to prevent them from, I would just like to say that when we think about performance, there are both financial and non-financial incentives that you need to be thinking about. So it's not just about like a number or in fact, I think if you look at some of the performance, motivators and demotivators, it's more of the non-financial incentives that, actually motivate health workers to perform things like recognition for their work, things like, diversity and responsibility. So these are things that actually motivate people to, be more present and feel more satisfied with their job, and therefore, could lead to like reduced, going out of the system, or reduce corruption, or being forced, to face some of these pressures to abuse the system. So from my perspective, I would say that.
Shreya, can I just pitch in?
Yes, please.
There's just an example. Again, people from the Indian context will understand, the others may not. The central government institutions in India, that is the prestigious medical institutions in India, do not have private practice. In India, that's a very strange thing. This is the non-monetary incentives you're talking about. For instance, if you're working in All India Institute of Medical Sciences, or JIPMER, which is the Pondicherry Institute, you do not get to do private practice, and you don't miss it. You don't do it because it's the prestige of being a teacher, a professor, and a practitioner in that institution. Whereas most state governments have not been able to enforce it. As a matter of fact, if we see the old rules in Tamil Nadu, we did read them. They said that people could practice, but they can put a board only outside their homes. This was meant to have an available pool of medical practitioners in case of emergencies. Now, slowly that has undergone a complete transformation where people do clear dual practice and work in private institutions also. So I think the original purpose of dual practice was very different in the States. And it was to make sure that people don't go home and don't close their doors and not be doctors for the rest of the day. So I just wanted to share that perspective. It was news to me when I read it.
Thank you very much. And there are two questions which are a little bit overlapping. There was a question about, do we need talking more about corruption, and do we teach undergraduates? Is this something that we need to really be more explicit about instead of doing programs and hoping for the best? And another question, Sarah Bennett, how do we research that? And do you know any good examples of initiatives where they've changed the sort of views on corruption? Policies have incorporated social norms and trying to really make a difference. So I would like to invite maybe Veena to make a few comments.
So I'm actually going to turn this back over to the panelists, just because I think this is very much what they have been speaking about.
Okay,
maybe
great.
And because we only have a couple more minutes, maybe right. I can ask each of you to provide maybe a quick 15-20 second response to the question that Dina just raised as a form of concluding thoughts as well.
Or if you want, I would like to just say we had these questions about that we posed to the audience, to everybody, about what has worked and what do you think can work. What is your prediction, or what is your recommendation for anti-corruption strategy in context you know? Just maybe final comments. I would like to invite maybe Marta to start.
Sure. So my 10 seconds is, I think some of the social accountability efforts that have really focused on community level dialogue, while it's really challenging to think about scaling that up, it's a platform through which communities can share the harm and healthcare workers can share the constraints that they're working under. And second is there have been some efforts that I'm happy to share offline of sort of systematically identifying and harvesting ground level innovation to reduce corruption and then trying to scale that up. And so it's very sort of focused on local solutions.
Girija? You're muted, Girija. she froze. So maybe I'll hand over to Shreya.
I'm actually just going to just echo mainly what Marta said. I think like bringing in communities and it's sort of not just communities. I think the different stakeholders that are involved. We talked about both the politics. I don't think we engage as much with the political side in terms of research as well, because it's just so complicated and such a difficult subject to touch. So I think really engaging with all the stakeholders that are involved, in this nexus and really understanding all of those perspectives and bringing that in could be, a good way forward. But I'll stop there.
So we are actually out of time. So I wanted to wrap us up here and thank all of our amazing panelists. And thank you, Dina, for the fantastic moderation. This was a brilliant session. We're very happy you could be here and hope to continue the conversation online and in other forums. So thank you so much, everyone. Have a good rest of the conference.
Thank you very much. And thank you for the very interesting questions.
Thank you, everyone.
Thank you very much. And please get in touch with us. We couldn't answer everything, but we'll be trying maybe by email.
Bye-bye.
Absolutely. Bye, everyone.
Bye-bye.
Bye.